Hello, everyone. Good morning. Let's jump right in. It's 4 minutes past, so let's go ahead and jump right in. My name is Myra Martinez. I'm a patient advocate with the UPA. I live with acute intermittent porphyria myself. We're also really happy to have Dr. Bruce Wang here with us today. He is a porphyria expert at the University of California at San Francisco. He's also a porphyria expert who has done multiple webinars with us in the past. And along with him, we also have porphyria advocate Nicolas Frias, who will be leading us today through the presentation on medication safety and how to use the drug safety database. So without further ado, I'm going to turn it over to Dr. Bruce Wang, our porphyria expert. I'm going to let him tell you a little bit about himself. He's part of our UPA's scientific advisory board. So, Dr. Bruce, take it away.
Thanks, Myra. Happy Saturday, everyone. Very glad to be here. And I want to thank the United Porphyrias Association for putting together this webinar, because medication safety in the acute porphyrias is a very important topic, and it's a common question that not only patients have, but other providers have as well. So as Moyer said, I'm a physician specializing in porphyria care. I'm a liver doctor, a hepatologist based out of the University of California, San Francisco. I've been running the UCSF Porphyria Clinic and have been part of the Porphyrias Consortium for the past decade or so. And I'm really glad to have Nicholas Frias today with us in this webinar. Nicholas has been really involved in making drug safety information widely available to physicians and patients in the US. Nicholas, I'm going to hand over to give you a chance to introduce yourself.
Yeah. Well, Nicolas Frias here. I am a software developer by trade, and I have myself acute intermittent porphyria. My sister died many years ago of complications from a severe attack that got made worse by administering the wrong medications. This happened in Spain many years ago, whatever, but still, it made us very aware, and we were always carrying a large sheet with all the names of the medicines that we could find in all the different sources. And finally, I decided, oh, well, wait a second, I'm a software developer, I can do something about this. And I created the Porphyria app that you will see in a little bit. Dr. Wang.
Yeah, so I think that what we will do is I'm going to start by giving a little bit of background about why drug safety is important in the acute porphyrias, and then we'll get into the meat of our presentation, which where Nicholas will walk us through the current drug safety databases, how do we navigate through them, and what do the different categories mean. And then in the last part, Nicholas and I together will then talk about, well, how do we use that information of drug safety to ultimately make the decision, should I be taking, is it safe for me to take this medication? Right. And we'll try to leave some time for questions at the end. So I'm going to share my screen here. All right. Hopefully everybody can see my screen here. All right. Okay. So who does drug safety affect? Which porphyria patients need to be aware and careful about medication safety? And I want to start off by emphasizing that really it's only the patients with the acute hepatic porphyrias, and that includes acute intermittent porphyria, those with variegate, hereditary copro, and the rare ALAD porphyria patients. And it's important to note that those patients with the cutaneous porphyrias, for example, erythropoietic protoporphyria or EPP, and the related XLP patients, porphyria cutanea tarda, and congenital erythropoietic porphyria patients, those patients who have only sunlight-induced skin lesions, those patients do not have to worry about medication safety, about medication-inducing skin symptoms. Okay, so this talk and medication safety in general really only applies for patients with AHP. So then why are AHP patients susceptible to induce acute attacks, these acute neurovisceral attacks from taking certain medications? Well, so we're going to talk about the main reason is because the one organ that breaks down medications, really chemicals in general for the body, is the liver. And for the liver to break down medications, it has to use machinery that contains heme as the main part of that chemical breakdown machinery, which primarily consists of a group of enzymes called cytochrome P450 enzymes. Right? So these are basically enzymes that break down chemicals, and heme is a major component of all cytochrome P450 enzymes. And so in patients with one of the acute hepatic porphyrias, when they take a medication, it's possible that that medication may increase the production of heme, specifically in the liver. And it's in that setting that that can lead to an acute porphyria attack. Okay, so I want to illustrate this a little bit using, showing how this actually works in the heme biosynthesis pathway. So what I'm showing you here are the 8 steps in the heme production pathway, where you start from these 2 starting materials, and through these intermediate manufacturing products, you end up with the final product of heme. And here are the 8 worker steps or enzymes that take each one of these starting materials, make it to the next step, and then take each one of these intermediates to the next step until we get to heme. And the porphyrias, as you guys are probably all aware, are due to, I'm showing you the 8 different porphyrias or names over here. They are each due to a partial defect in any one of these 8 enzymes over here. And as a result, you can get abnormal accumulation of the intermediates that are made here before you get heme. And that's why patients with acute porphyrias have their different symptoms. Now, we're talking about the acute hepatic porphyrias. These are the ones highlighted in red over here. And in the acute hepatic porphyrias, it is, we all accumulate high levels of ALA and PBG, and these are the chemicals that cause the neurological symptoms. Okay, all right, that's a little bit basics of acute hepatic porphyrias. But why? Now, these are all genetic disorders, right? And I think some in the audience, they may have had acute attacks in their lifetime. Some patients may have frequent recurrent attacks. But if you think about it, if this is a genetic condition, why aren't these attacks present all the time? Why are these only sporadic attacks? And why is it that some people can have the genetic mutation and don't have attacks at all? Okay. And the reason is because what I'm trying to show here in this diagram are, again, those same pathways with the same enzymes. And I'm showing you here as kind of a pathway here going from left to right. And the size of each one of these discs is meant to signify the approximate level of activity. How effective is each one of these enzymes in the heme biosynthesis pathway? So the larger the disc, like in this particular case, ferrochelicase, the last step is really effective. Okay. And the whole pathway, as you'll see, the narrowest, the least effective, the enzyme that works, at the slowest rate, if you will, is the very first one, ALA synthase 1. And in patients who have mutations in one of the acute porphyria genes, we're going to talk about most common ones, PBG deaminase, that's the enzyme for patients with acute intermittent porphyria, for example. The level of activity of that enzyme, even when in a patient who has a mutation, so that that enzyme doesn't work as well as usual, right? Could be working at 50% of usual capacity. That partially defective step in an AIP patient is still more active than the very first step. So even in a patient who has a defective heme production step, it's still the first step that is the rate limiting step that controls whether or not the whole pathway goes. And so in that case, the mutated enzymatic step is essentially masked. And in those patients, they don't accumulate high levels of ALA and PBG. They don't have symptoms. Okay. So Well, so that's what I'm saying here. Even with a mutation in the heme pathway, the first step is still the rate limiting step most of the time. Okay. Now, there is one cell type, it's the main liver cell, the hepatocyte, which is really essentially the only cell type in the body where the activity of this first enzyme, ALA synthase 1, can be really increased very significantly to many times its baseline levels. And what are the things that can increase it? Well, this is mainly what we're talking about today: medications, drugs. You'll see here sex hormones in women, especially progesterone. Changing levels of progesterone can affect it, prolonged starvation, alcohol. But drugs, medications is the main thing that can induce this first enzyme to work much more effectively in the liver. And that happens because the liver has to make more of the cytochrome P450 machinery that requires heme. So in this context of there is a mutation downstream, and now you increase ALA synthase 1 activity in the liver, this is how you get the context in which you can have an acute attack. So this is what I'm showing you here. Just having a genetic mutation, let's say if you're an acute intermittent porphyria patient, that by itself is typically not enough for you to have an attack. You have to combine that with some other environmental or physiological trigger. And we're going to talk about today is that medications, certain drugs that will increase the demand for heme in the liver. And that then drives increased activity of that first enzyme. This now unmasks the partially defective heme production step downstream as the new rate limiting bottleneck step. And so now in the liver, you start getting accumulation of these heme precursors, ALA and PBG, and that's the context that you have an acute attack. Okay. So this is why we're talking about drug safety databases, is because medications can trigger acute porphyria attacks in AHP patients. And because of that, these databases were first created to provide information about potential risk for certain medications to induce acute attacks. Nicolas mentioned the printout sheet of papers, so that to remind them of, hey, when the situation comes up, here are the medications that pose really high risk. And having access to that information has been very important for and helpful for porphyria patients and providers. And over time, over the past several decades, there's been several separate drug safety databases that have been created kind of in parallel. The US has had one, Europe has had one, South Africa has had one. Then over time, these databases had varying degrees of maintenance and update, and then they became conflicts sometimes between them. And uh, currently, we've kind of undergone a restructuring, if you will, of drug safety databases. And currently, as far as I know, there's really only one actively monitored porphyria drug safety database. The main one, it is housed in the Norwegian Porphyria Center, or NAPOS, and it is actively maintained by porphyria experts actually from around the world. I'm the main person from the US who's part of the group that maintains this drug safety list, updates it, adds new medications. The folks from Europe are involved, and folks from South Africa are involved. All right. So now, Nicolas, I'm going to hand it over to you. I'm going to stop my share and hand it over to you so that you can give a demonstration of what this drug safety database is and how how people can access it.
Yeah. All right. So a quick background. I started this because, as Dr. Wang explained, there were several databases and they were cumbersome to access. You needed to be online. So didn't use them very much for that reason. So I'm going to share now my screen. Share, there we go. And in the in the United Porphyria Association page, under resources, you have drug safety for hepatic porphyrias. Well, come on, there we go. See it? Sorry. Oh, for some reason it's not going now. Okay. Oh, sorry. The website is going. slowly for some reason. Well, if not, I'll jump straight to the porphyria. Okay, so I don't know what happened with the site, the UPA. In any case, here is the app. The app is available. It works well on a phone, in a mobile phone, and that was part of the purpose of this, so that you could have it in your phone and it doesn't require a connection. Once you download it, it's in your phone and it works without a connection anymore, and it has all the database. What I have done is basically what I would consider better interface to the same database NAPOS. The only things to show here is the first thing, of course, is the safety rating that is up front, and I'm going to let Dr. Wang explain what that means.
Right. So, drug safety, there currently have been broken up into 5 categories, and these are relative safety. Okay. And actually, I'll also preface this by saying that in terms of drug safety for the porphyrias, there is a lack of good, reliable information for a lot of these medications. There are a small number of medications that have very well documented, have, triggered clearly acute porphyria attacks, where we can tell in patients not only that they have attacks, but also that we can show that it severely induces high levels of ALA and PBG. As you can imagine, when a patient is with acute porphyria is taking a new medication, it usually is because it's in the context of something else that's affecting their health. And oftentimes we may be starting multiple medications at a time, for example, in a hospital setting. And so it can be really difficult to really be able to accurately tease out what is the inciting medication or not. And sometimes it's hard also for us to figure out whether or not a patient's set of symptoms are really an acute attack or not. So this is all just to say that we actually really do have a lack of good information in many cases with medications. And part of that reason of that lack of information is why when you're seeing the safety ratings over here, they're not so clear cut. You've got 3 categories in the middle that are probably, possibly, probably safe, possibly safe. You're like, wait, what does that actually mean? Really, what that means is that we don't really have enough data in there to really be able to say very convincingly and with a lot of confidence that a drug has, really has never been shown to induce an attack. Those are the ones that are in the safe category. Drugs that have clearly been shown to trigger acute attacks, those are the ones that we can more clearly, confidently put in the unsafe category. And then you have medications, for example, new medications that have come out that we don't know if it's ever been used in an acute porphyria patient. And the only thing that we can base this categorization on are what we know about how that drug is metabolized. Is it known to induce heme, for example, in things like cell culture studies, studies in a petri dish? Is there anything known about animal studies? Is there anything known about other cases? So because of that, we have now 5 categories, 3 of them that are kind of, varying ranges of relative risk. In general, the medications that from what we understand about how that mechanism, that chemical is broken down by the liver, if it doesn't really induce a cytochrome P450 system, it's going to be in that probably safe category if there's not much actual clinical information known about it. If it's a medication that clearly is broken down by the liver and would require the cytochrome P450 system, and there hasn't been much, data that's been used. It depends on how much it is known to induce it. It might be put into either the possibly unsafe or the probably unsafe. Okay, so that's a little bit of explanation of why we have so many different categories. I think we'd love it if it was a little bit simpler. It could be easier for patients to be able to interpret this information and then to add it to their decision making. But this is why there are 5 categories. On the 2 ends, pretty straightforward. These are the ones that we have a lot of data on that we can trust. And then we've got 3 middle categories where we don't have quite enough information. So based on what we know, this is what we think is the most likely outcome.
All right. I'll guide you through the interface here a little bit. Some basic things. It's in English, Spanish, and a couple other languages. The languages with the star have been translated with machine translation. So the translation, and I'm talking here about the translation, not of the drugs themselves, but of the page, of the information on the page. For the translation of the drugs themselves, it's more complicated because it has to be, properly vetted and all that. And at that point, I'm talking about the generic name, which is what you should try to use every time to look for a drug thing. We can get to Naples from here, just so you see what Naples looks like. And here you can do a search also. This would be directly on their database, and they have the same risk classes, and they have a couple other things. But the main thing is the search. And what I do is I provide basically the same the same search, the same data that Napos provides. The only additional thing that I'm doing for the American market, let's say, is that I'm including brand names that the Napos database doesn't have because they are American names, and it costs a lot of money to get those, so we are getting them however we can. That is to say that the safest way to use this is to use the generic name that I highlight here. Use the generic name of the active ingredient. And if you don't have that, maybe you can go through the brand name of the drug that you're looking for. And that is a lot less safe in a way of, or accurate, let's say. We also have information about the countries where the drugs are marketed. That's less useful, but it was interesting. So we included it, and Napos was including it, so I did so too. A few useful links for Napos. American Porphyria Foundation has a couple of good information things too, UPA and whatnot. Just in case there's some settings and privacy, if you don't, you have to do these things, privacy stuff. But there is something interesting here is the strict mode. Originally, the American Porphyria Foundation, which is the database that I was using, only had 4 categories. It merged these two, possibly unsafe and unsafe, and probably unsafe together. That's just a historical thing at this point. Okay, so let's try a quick search. I'm gonna select, let's see, oops, wrong keyword. So as soon as you start typing, you start getting hits. See, so you know immediately whether you type it right or not. Atorvast. There we go. Atorvastatin. I was looking for this one. So as soon as you start typing, it shows you the generic name, the rating immediately, what type of drug it is, and brand names. Brand names, as I said, are taken with machine learning kind of thing, with automatic means, because there is too many. In some cases, there's just too many, and it's overwhelming. So we had to take away, among other things, because they would tell you the dosage and the packaging and all that stuff in the database, and that's not relevant for what we need. What I wanted to make sure is that to get at the information quickly. And if you want to know the countries, you click on the flag, and it tells you, it's a little busy, but it tells you what countries market under what name. And the important part here is this link. This is called the ATC code. It's a code that is used by many databases to identify drugs. And then from here, you can get to what's called the monograph in the Napos site. And here it gives you, this is for the doctor, obviously, more information, in-depth information about why it's considered safe, unsafe, or whatnot, the classification. So that's what that link does. And these monographs are being translated right now to at least to Spanish and probably to other languages. It's in process, but it's happening right now. I'm in contact with the people at Napos, and they're doing a great job right now. So as you can see, in this case, this is the same as Lipitor, so atorvastatin. You can also type Lipitor, and it finds it by, as you can see down here, finds it by the brand name. The only problem with brand names, as I said, is if I type Tylenol, right? Tylenol is considered mostly, safe, but oh, oops, comes here in an unsafe. And this is because it's a mix. It's Tylenol with something else in this case. So, and that's why I say don't rely on the brand name. That's a suggestion, is a way of understanding a little bit better the data. Always the generic name is best. I'm going to show you a couple of other interesting things that you need to consider. What is this? Damycin. Okay, this drug, for example, comes in in a couple of flavors, depending on the usage. This is for acne use. This is gynecological, and this is antibacterial, and it varies. So in some cases it shows as safe. In this case, it's because it's part of some compound thing, and that is to say, you have to exercise some degree of care when you look at the database. Let's clean this up.
Yeah, Nicholas, if I can add a quick comment to
Yep.
this one. I think the last two examples that Nicholas demonstrated with Tylenol, or acetaminophen as
Yeah.
the generic active chemical, or an antibiotic like clindamycin here, is this is why medications and medication safety can be so complicated. So you can have one active compound like acetaminophen that can be part of a component of many different mixed medications, and so that can be an easy source of confusion for patients. And then with antibiotics like clindamycin, even though it's the only active ingredient, but it can be in several different forms. It could be a topical, it could be as an oral pill, it could be as an injected medication. Some medications the same form can be available as a rectal suppository, for example. And each one, and actually the differences in the way that the medication is delivered and the dose also matters in how safe something is. So those are just some additional information, pieces of information that you guys can try to keep in mind, eventually as you're searching for information about the medication safety in your specific case. Is that the way that the medication is delivered? Is it going to be part of something else? Those things also do matter here.
Yeah. The other thing that I wanted to say a couple more things, obviously. One is, as you can see, this database has 1,400 records or so. It does not include all the records of the NAPOS where there is no information. In NAPOS, they tell you, oh, this drug, we don't have information. I did not include those things in here because it will just bloat the application. And in the disclaimers, I say, if you don't see it here, assume it's unsafe. Check it out, do due diligence. It's important to consult with your doctor and all that. It's always important to do that. The other thing that is interesting is you can check for example, antihistamines. So if I type antihistamines for systemic use in here, so it's searched by type. In case let's say you need an anti-nausea, right? You don't know which one you can do, and instead of going by one, you can say anti-nausea. There you go, anti-nauseous. See, you can type that in. Oop. Sorry, there we go. So, and then it will give you several alternatives in case you're looking for alternatives for a particular condition. So it's a way to group things. Actually, I don't have much more to say about this. Always refer to NAPOS. This, as I say, I take from NAPOS data. At this point, I think I'm going to do it once a month. And up here you see the date of when the data was collected. I mean, gather from Napos. And Napos now it's updating their database more often than they used to. They have a system in place and they now have the resources to maintain it, which is a big deal. I think
Nicholas, I think one of the great things about this, what you've created, this interface, so that we can better, more easily access the NAPLS database, and have added these additional features to it, is that we can access this through our mobile device as well. Can you just walk folks through how they would get this on their mobile device so that they don't have to go through their browser app? And then would the interface look any different on their on the mobile device?
not really. The interface is the same. And basically, here's a little explanation of how to get it in your phone. Basically, you go to your phone or go to the porphyriadrugs.com in your Safari browser if you have an iPhone, or in your Chrome browser if you have an Android. Windows, I don't know what other operating systems really are there for phones, but basically you go on your phone with your browser to this page, and that should be it. And then you can say add to the home screen. There's different depending on the phone how you do that, but it's usually a little icon with an arrow up or three dots in the case of the Android, and there is some version of add to the home screen, and that will add the porphyria. I don't know if you can see this. I have in my phone. It's a little, there we go. So this little icon there with a P, which is the same P that is here, will appear on your phone, and then you click on that and you have the exact same interface. Let's see if that, see, it's the same interface. You have can you see what I'm showing? I hope so.
Yes.
Okay. All
Yep.
right. So yeah, so it's the same interface, exactly the same interface. I try to keep it simple and consistent so that there is no. The purpose of this application is simplicity. It's a quick access so that you have it. If you're in an emergency room somewhere and they're going to give you something, you can check it out first, and then you can start a conversation with your doctor about the safety of whatever they're giving you. And that was the main motivation for me to create this. And hopefully at some point this will be folded into Napos itself. We are talking about that, but right now it's mostly a quicker interface. And to be honest, I like the fact that you can just start typing here, and it will sorry, wrong keyboard, and it will give you immediate feedback, so you know whether you are typing the right thing or not. It used to be that you had to type the whole word, and if you mistyped it, good luck, you will not find it. Now it's a little more. You get feedback immediately, so you know what's happening. And the rest of the app is that's it. It's very simple. Just the languages. The text is in Spanish, but the drugs in this particular case, I think the drugs are in Spanish also, because we got the names, the proper generic names in Spanish. For other languages, the names revert to whatever default we have, which is either English or Spanish, mostly. And as you can see, the languages that we have right now are mostly European, because that's where they're putting the effort to maintain the database. I think that's about it. Oh,
Okay.
this is a historical thing. I had put a comments section down below in case people had comments, but mostly my replies are, I don't know. You need to you need to ask to your doctor, because I'm not a doctor, obviously. That's it.
All right.
Okay.
Nicholas, this is a great resource. Thank you again for all that time and effort you've put in to create this and to maintain it.
Mhm.
So I think in the next section, what I want to talk about is, all right, so now we have this really good resource that's available that tells us about on the medication side, what is the relative risk for that medication. But how do we use that information, right? Because ultimately, I think the question that that we have is, that for a patient or as a provider is, if I have, AHP, based on, my own experience, my own risk factors, disease severity, should I take this medication, right? And I think in all of these cases, whenever you have to make a decision whether you're going to put something in your body or not, is you have to decide. You have to figure out, well, what's the benefit of me taking this new medication, and what's the risk of it, right? And the thing I want to emphasize here is that medication safety. This is only part what we just talked about. The information that's available about how much a drug may induce an acute porphyria attack, that is only part of that falls obviously on the risk side of this balanced equation, but it only forms part of that equation. Okay. It's I generally think of three different factors when one of my patients comes to me and says that, hey, my cardiologist asked if I can take this medication, all right, for whatever reason. And usually, on the risk side, I think of these three different factors that then we put together to then finally assess what the overall risk is. And then we have to weigh that against what the benefits are. Okay. On the benefit side, it's, how important is that treatment? And then also available alternatives, right? Nicolas showed us that if you can put in a medication class, and it will give you alternatives. So if a equally effective alternative medication is available that has lower risk, all right, well, that helps. That's part of the decision making on the benefit side. But drug safety, we've talked about that. That gives you some idea of, hey, has this medication been known to induce attacks? Has this medication never been known to induce acute attacks, but been used a lot, right? But in addition to that, I think the two other factors that I think we should consider is, number one, well, what's the severity of my acute hepatic porphyria, right? And then the second one is, what's my access to treatment? If I were to have an induced attack, how bad is that for me? If I have access to treatment, my decision making here, the amount of risk I'm willing to tolerate is probably a little bit different than somebody who, the nearest place where they can get panhematin is, hours away. Right? So first, I want to talk a little bit about AHP severity here. I mentioned earlier that we talked about how not even patients who have acute hepatic porphyria mutations, and even if you've had attacks, you don't have attacks all the time. And there are many patients who have the disease-causing mutation but never have attacks, right? So the disease severity of AHP is quite variable. One other way to think about it is that we can group now acute hepatic porphyria patients into a couple of different clinical categories where this gives you maybe a little better idea of your disease severity. This is based on some data in the US Porphyrias Consortium, where if we think about all acute hepatic porphyria patients, I'm talking about all patients who carry a mutation that can cause acute porphyria attacks. That's quite a lot of people. It's probably 1 in 1,500 people have a disease-causing mutation. Okay, but of all of those people, the vast majority of them, 98% of them, they are not going to have any acute porphyria attacks in their entire lifetime. Right? So the vast majority of people, just having the mutation doesn't mean that you're going to have attack. In fact, the vast majority of people never have attacks in their life. We can even break up this, further separate this group of 98% even a little bit further. Within this group, again, the vast majority, they just, the only way you would know is if you did genetic testing. Okay? They have totally normal ALA and PBG levels if we check it in the urine. And these patients have no symptoms, and they probably will go through their entire lifetimes without any clinical consequence of a porphyria attack. There's a small percentage of patients who don't have attacks, who don't have symptoms, but they actually do have high levels of ALA and PBG. These patients are a bit of a special category in that we need to understand and study these patients more to better understand their potential risk. All right. On this side, these are a small number of patients who have acute porphyria attacks, probably somewhere like 1 in 10,000 people, 1 in 100,000 people, somewhere in that range. And even within that group, most of them have one or a handful of attacks in their lifetime. And then there's a much smaller number who have recurrent attacks. If I just look down here across these four different categories, you can think of this as the lowest risk or the lowest kind of disease severity, and these patients have the highest disease severity. Where you fall along these four clinical categories, and if you're in here as having had acute attacks, how recently have you had attacks? How many attacks have you had? What are the contexts in which you've had attacks? Those are all additional information that is really important when we factor in, that should be factored into here when you're assessing your risk of taking any particular medication. If you're somebody who carries a genetic mutation, has never had an attack, have normal levels of ALA and PBG, your AHP severity is probably really low. In that case, you may be able to tolerate a medication that has potentially a higher risk. All right. So the final point I want to make is that no drug is absolutely contraindicated in acute hepatic porphyria, right? Um, the reason we're talking about this is because having an acute porphyria attack is awful, right? It's an awful experience to have to go through. It can be life-threatening. Patients have died from it. Nicolas has personal experience from that. So we want to be very careful with that. But I do want to mention, emphasize that on the other hand, the benefit of this medication that you are considering whether or not to take, that can also be potentially life-saving. Right? Somebody who, for example, has a severe, serious infection and needs an antibiotic and that you don't have any other alternatives, the potential benefit is really great. And so we may be willing to tolerate a lot of risk because the benefit is, right? So I think in each one of these scenarios, it's a risk-benefit analysis. And I would say also, when in doubt, ask for help, ask more information. I get these questions all the time. I'm more than happy to answer them. The UPA is very good, has been excellent in fielding questions and directing them to folks in the porphyria provider community who can help answer these questions. Sometimes these are very complicated decisions where it's not quite so simple as, well, how safe is this medication? Because as you see here, we have to take additional factors into consideration here. And so this is just to emphasize that the drug safety and the information that's available in these drug databases is only one piece of information out of a number of additional ones that we should be considering to ultimately make the decision, is this drug safe for me to take in my situation? Okay. And the last little bit I want to mention, there were a couple of questions already in the actually I forgot to mention this. There was a question about treatment if if somebody is on gavosaran, for example, does that make drugs more safe for the patient to take, right? So if you're on treatment, I'm going to say that falls. This is what I think about when I think about access to treatment. Okay. In patients who are on gavosaran, it's not necessarily that the drug safety itself has changed very much. It's that if you have access to treatment, or if you're already on a treatment that really helps suppress your ALA and PBG levels by suppressing the level of ALA synthase 1, you probably are overall more protected. Right? That you're able to tolerate more risk. And I'll add on to top of that, my patients who are on gavosaran, I'll usually also tell them, hey, you're already hooked into active porphyria care. This is the situation where if the benefit to the medication that you're considering is is quite high, we are willing to tolerate more risk. You have access to care. You have access to get panhematin set up. If we know, for my patients who have access to infusion centers where we can do as needed panhematins and tell them, look, we'll get everything set up beforehand before you're about to start this new medication, and we'll watch carefully. We'll check ALA and PBG levels. There's a plan that we can put in place to monitor so that in that case, you could take a drug that is listed as an unsafe medication, but we can still get somebody through it. Even patients with history of frequent recurrent attacks, where we think that there's a high chance of it inducing an attack, we can still treat that patient through if they really truly need this other medication. Okay, but if you're on gavosiran, that does actually probably overall decreases your risk because of some of the things that I mentioned. So the last one, I just want to mention that there is active ongoing research on drug safety in the AHPs. So Nicolas and I have talked about the NAPO's website. So there is a drug safety working group, and it composed of myself from Apex in the US, folks from IPNET that's the International Porphyria Network in Europe, and two South African physicians, and a number of pharmacists. And we evaluate new medications for drug safety. We update the existing monographs. And so that monograph that Nicolas showed on the NAPO's website, they're being modified and new ones are being created all the time. And we are also trying to capture new information. So in the US, there has been this active study called the Evidence-Based Assessment of Medication Sensitivity in Acute Hepatic Porphyrias. It's basically a drug safety study. Okay, this has been ongoing for close to 10 years now. It used to be housed in the Office of Rare Disease Networks as part of the NIH. We have moved this. Now the database is housed at UCSF, where I am, and it's continuing to be sponsored and supported by Apex and the Porphyria Consortium going forward. This is an online questionnaire where we ask patients to help put in reports about both safe and unsafe drug use. So you've taken a medication and you had an acute porphyria attack, and we'll provide this website link. I try to put it up. It's actually currently the website's currently down at UCSF, but we'll provide the website link to the UPA and we'll distribute it to everybody here, and we can probably post this onto the link to this webinar on the UPA website so folks can access it. But the goal for this study is to try to capture more evidence-based data. And we're going to be asking patients in there about, did you have an attack? What treatments did you need for the attack? Did you have ALA and PBG levels that were checked? Because we found that in a lot of cases, there are lots of reports of unsafe use, but there's very little data associated with those reports. So it's been very difficult to assess the quality of the data related to reports. So this study is really aimed at trying to improve the data quality of drug safety reports in the AHPs. All right. So I think that's the end of my slide. So I'm going to stop
Awesome.
there, Myra, and I'm going to hand it back to you.
Fantastic. Thank you both for that thorough explanation. Honestly, I had seen porphyriadrugs.com previously. Nicholas, I had not understood that someone of our very own, within our very own community, had developed it. So thank you so much for the time, the effort in creating such incredible resource. It's been a tremendous resource for myself and for my family. And as I see a lot of heads over here, they're nodding like this is fantastic because we all depend on this list. And Dr. Wang, thank you so much for explaining in detail. I did learn that I had no idea this, and I actually work with the UPA, and I just realized that it's on our website. If you go onto porphyria.org under resources, you click on the resources. If you're on your phone, click on the resources. It has the three three lines. You click on resources, and then under resources, there's that drug safety for AHP, and it throws you directly into porphyriadrugs.com. If you forget how to access it, that's the easiest way to access it as well. Just a reminder, this is something that I did not know that we should look for the generic name for that drug in order to get the appropriate information. So just a couple of takeaways that I wrote down that were important to me. So I wanted to make sure that you guys took those away as well. Let's jump into the questions. What do you say? We have a few questions in here. So let's go ahead and jump into that. The first question, does this process, referring to the process that causes acute attacks, does this process damage the liver directly? I would imagine it's referring to the constant attacks, whether if it's a one big attack that we get, Dr. Wang, or multiple attacks that we get throughout our years suffering with porphyria. Does that damage the liver directly?
Yeah. So kind of 2 points on this. Number one, acute porphyria attacks themselves actually typically don't cause much damage to the liver. So even though the liver is the source of buildup of the chemicals ALA and PBG, we only find mild liver inflammation based on blood tests looking at liver enzyme levels, which is quite sensitive for picking up liver inflammation. We only see elevated liver enzymes in maybe 15% of the cases, of the time during the middle of an acute attack, and it's usually quite mild. And usually those liver enzymes go down pretty quickly after the attack. And on top of that, even patients with a long history of recurrent acute attacks or those who've had severe prolonged attacks typically don't have much evidence of chronic liver injury. For example, the incidence of cirrhosis, which is which is scarring from many, many years of ongoing liver injury, that's quite rare in the AHP population. So the acute attacks themselves, we don't think damages the liver so much. However, I do want to mention that there is a higher incidence of liver cancer, tend to be in patients who are with AHP patients over the age of 50, and probably that risk is higher in patients who have had attacks. So that is something to consider. So even though there isn't much in terms of inflammation and scarring in the liver, separately, it's probably is doing something to the liver that causes it to increase the risk of liver cancer. Separately, I think I should mention that since we're talking about drug safety here, many medications actually directly damage the liver. So that's not related necessarily to the AHPs, but actually a lot of times when a patient has to start a new medication, what probably happens more often is that they get signs of liver enzyme elevations. Lipitor, for example, that Nicolas showed with atorvastatin, even though quite safe in the acute porphyrias, in quite a number of patients and cause liver injury itself. So that's something else for us to think about when we're thinking about liver safety in the context of AHPs and medications.
We take that for granted oftentimes. I have found, to be honest with you, I watch people who don't have a disease like we do that we constantly have to be thinking about our organs. But I'll watch someone who is perfectly healthy otherwise. They will take an Advil, pop two, three, like it's nothing, or a Tylenol, like it's nothing. And here I am thinking that is going to damage your one of your organs is going to have to clean that up, process all of that up, and you're not thinking about that. And I find that it happens quite often. So I feel pretty special that we know us in this webinar have much more knowledge than the regular Joe out there that might not realize the amount of damage that perhaps that one pill could really be causing them. Because they might not be thinking about it every single day. For sure. All right, the second question. Can you change from a symptomatic high excreter to someone who does have attacks, perhaps by having unsafe medication?
Yes, well, we've definitely seen patients transition or change from the asymptomatic high excreter into having actually tends to be more often recurrent acute porphyria attacks because those patients with recurrent acute porphyria attacks also tend to have high levels of ALA and PBG even in between their attacks. But there are also a well-characterized population of patients, first characterized in the Norwegian countries, Scandinavian countries, who actually can go through their entire lifetimes without having acute porphyria attacks, but have high levels of ALA and PBG. So this is why I mentioned that cohort of patients is one that we don't understand enough about because there are still a relatively small percentage of patients who carry the acute porphyria gene mutations. And so that those patients, we need to understand more about them. But it is possible that if you're found to have high levels of ALA and PBG, that your risk of having an acute porphyria attack, I think generally I can safely say that, confidently say that your risk is probably a little bit higher than the similar patient, but who has normal levels of ALA and PBG have never had attacks. I do think that your level of ALA and PBG at baseline is an important part of assessing your risk. And the higher it is, probably the higher your own risk is of having an attack down the line.
Fantastic. Okay, this is the last question. Unless anyone else has any more questions, please drop that into the chat now, or else we're going to wrap up after this last question. But last question reads, this is a big question not answered by my hematologist. I am an 88-year-old woman that still has active AIP attacks, but not as often. Is there an age when these attacks quit? New drugs have thrown me attacks, into more attacks. So the question there is there an age limit on when these attacks might end? And can those new drugs cause attacks, which we just learned that they do cause attacks?
Yeah, so I'll try to answer that question. So I think to answer that question, I think first I'm going to um, uh, I'm going to define what I call an acute porphyria attack, right? So obviously, people here are familiar with the symptoms that you can experience during an acute attack. My definition of acute porphyria attack is having those symptoms in the context of really high levels of ALA and PBG. And I probably add that it's higher levels of ALA and PBG than your own personal baseline, because some patients with frequent recurrent attacks kind of live at high levels of ALA and PBG, but an acute porphyria attack, to me, is one where you have the symptoms of the neurovisceral symptoms of acute porphyria attack, and your levels of ALA and PBG are higher. Okay. So the reason I want to mention that is, so to go back to the question, first, generally, women are more susceptible to having attacks than men, about probably 80-20 ratio, women to men. And in women, generally, after menopause, the attacks tend to slow down and go away, but not always. Right. So, as mentioned in this question, you can be in your 80s and still have acute porphyria attacks. Okay. But the reason I define the attacks as having, higher levels of ALA and PBG are for two reasons. Number one, we've talked about in here, today, that acute porphyria attacks, you can have a really long and severe acute porphyria attack, or you can have, many prolonged, many attacks in your lifetime. But each acute porphyria attack is an episode of neurologic damage, and you can have a long, prolonged attack that can cause permanent neurologic damage. In those cases, we've seen patients who experience recurrent symptoms that feel exactly like their previous acute porphyria attacks because it's the same nerves that are being sensitive and causing the symptoms. But the key difference here is that now when we look for levels of ALA and PBG, they're either no longer elevated or maybe they're only at baseline levels and they don't change. Okay. And the second reason that I want to emphasize, that that I tie together higher levels of ALA and PBG to my definition of attack is when I think about the things that we can do that are effective in treating acute porphyria attacks. Really, it's two medications, panhematin for the in treating acute porphyria attack and gavosaret in preventing an acute porphyria attack. Both of those medications work by lowering the levels of ALA and PBG, right? So in a patient who has recurrent symptoms that feel just like their prior acute porphyria attacks, but their ALA and PBG is normal, right? We have those patients. Giving panhematin and gavosaret doesn't really do too much to those. And so that's why I'm separating what I call an acute porphyria attack as symptoms with really high levels of elevation of ALA and PBG. So to go back to the question in this case, in patients with of any age, you are susceptible for having acute porphyria attack if you have an underlying genetic mutation. Okay, you're susceptible. You're going to be susceptible for your entire lifetime. Whether or not your active symptoms are due to an acute porphyria attack really depends on are the levels of ALA and PBG higher than your baseline when you're experiencing those symptoms. Okay. If they are, then we definitely should try to treat with panhematin and gavosaret, right? But there are a number of patients, especially those who've had either prolonged severe attacks in the past or frequent recurrent attacks, who may be dealing with permanent nerve damage, which is now separated from high levels of ALA and PBG, which caused the nerve damage in the first place. But that condition is no longer there. But now we're just dealing with the consequences of damaged nerves. Those cases are much more difficult to treat because we don't have good medications to help the nerves heal once they've been damaged and to dull now we're talking about things to try to dull the nerve sensations, and we also don't have great medications for those. So that's why I'm separating what I call an acute porphyria attack from just the symptoms. That if you're feeling similar symptoms, I think from a patient perspective that feels like an acute porphyria attack, but in terms of what we can be done with it, what can be effective treatment for that, I tend to separate whether those symptoms are associated with high levels of ALA and PBG or not. Okay, so I know that's a very long answer, but hopefully that helps answer that particular question a little bit.
It gives a lot of insight to that for sure. Okay, we do have one more question. It's a little unclear to me, so I will do my very best, and hopefully this will make sense to you, Dr. Wang. In 2021, at the Porphyria Symposium, Dr. Anderson said some patients confirmed to have AHP had follow-up attacks without elevated ALA or PBG. Do you know why this happens?
Right. So I think this is along the same lines of what I was just mentioning, is that it's a little bit, when we talk about acute porphyria attacks, we tend to just talk about the symptoms of acute porphyria attacks. And because acute porphyria attacks are nerve damage episodes, and damaged nerves even afterwards can still, they become more sensitive, they fire, and they cause the same sensations. But the reason they're causing the same sensation has changed now. Originally it was high levels of ALA and PBG, and now it's just the nerve is permanently damaged and not healing. So I think that's what Dr. Anderson was talking about, that you can have patients, and even amongst the provider community, sometimes we use the term attack interchangeably, and that can be a cause of confusion. There has been some effort over the last couple of years to kind of standardize what we call an acute porphyria attack and better define it so that it's not just based on symptoms, but that it's symptoms and high levels of ALA and PBG.
Mhm.
And I would add higher levels than your own baseline.
Right. Okay. Fantastic. Well, thank you so much. Those are all the questions that we have. We do have a couple more that will be answered afterwards when we send out the this as a full package that it has been completed and it's ready to be put on our YouTube channel. You will be receiving a survey at the end of this, which will include a link to that as well. So please do us a favor and complete that. We do have a couple other things that we would like to ensure that you know that are happening within our community, but I don't want to go into that until I say thanks once again to both Dr. Bruce Wang. Thank you so much, and thank you so much, Nicholas, for everything that you are doing for our community, for involving yourself into the community and providing so much insight and information to us. I personally have used this so often, and it has been a tremendous blessing in my life. So thank you so much for that. I do want to, I'm not sure if we have a slide, but we have an upcoming webinar with Dr. Cozumel, and that is because we had a lot of positive questions and results from the previous webinar that we had with him in regards to neuropathy and pain. We're bringing him back due to high demand that people wanted to have more questions for him. So we're doing this on Saturday, the 7th at 5 p.m. Eastern Time. We're going to be covering a Q&A specifically just to ask more questions about nerves, neuropathy, and pain specifically. Additionally, I want to encourage every single person that's here to sign up for our e-news. We constantly have different things going on. We want to make sure that you know what is happening within our porphyria community. If you go to porphyria.org, you're able to sign up into our newsletter. Additionally, from that, we also have connect ups. We make sure that every single month we have the ability for you to connect with your particular set of, whether that's a smaller community of people that have the exact same interest as you, and or individuals that share your diagnosis, so that you're able to be more in a cozy small friendship and family environment where you feel completely vulnerable and safe to be able to ask your questions. We also have a very growing UPA one-on-one ambassador program. That is a program that allows patients to connect one-on-one with another individual that has the same type of porphyria. Usually, these are individuals that are just being diagnosed. They get partnered with a person that has had their diagnosis a little longer, and they can understand what may be available as far as treatments, or just have a listening ear, quite honestly. And of course, we have our patient navigator between Aaron and myself. We're constantly fielding patient calls specifically to advocate for them, whether if it's in their diagnosis process and or they're in the hospital, they need some support, and we can be there for them to assist in any way to get them the help that they need. So it's one-on-one support. And then Porphyria Together, it's our booming, exciting group that we have on Porphyria. Together, it is a group, a Facebook group that is constantly lit up with a whole bunch of questions, concerns, issues, but also they're answered in this family atmosphere where people don't feel afraid to go on there and ask questions. So if you're not part of it already, I invite you to be a part of that as well. So once again, at the end, you will receive a quick evaluation when you get a minute. Let us know how this webinar was for you. Take a few minutes to share your feedback. This is how we get better. And also give us any ideas if there are any other things that you would like to hear from doctors or any other experts that you would like for us to host. This is a space for you. We hold this space specifically for you as the patient in mind, because we care about you. So thank you so much for making time for us this busy Saturday. You could have been doing anything else, but you decided to invest it with us. So thank you so much, Dr. Bruce Wang. Thank you again. And Nicolas Frias, thank you so much again for your time. Everyone else, please take care.